Hello, welcome back to the second week of the Closer Look Project Referral Network training program videos. I'm super glad that you have started to watch these with us, and I hope that you really learned something from it. Today we're going to discuss chapter 2 of the book, which is anatomy and lesion features. For the agenda, we have skin anatomy overview, benign lesions, pre-cancerous lesions, malignant lesions, and skin of color considerations. For the objectives, we are going to identify key structures of skin and scalp, differentiate between benign, precancerous, and malignant lesions, apply the ABCDEs rule for melanoma recognition, and recognize how lesions may present differently in diverse groups. I hope that these objectives are attainable for you, and I would love to have your feedback upon completion of each chapter. Skin anatomy. Why am I even teaching you this? So there are three main layers of the skin. We could break down the layers in more detail, but this lecture is primarily targeting personal care professionals. And while you learn skin anatomy, you don't use it every day. So I feel that it's more important to focus on just the brief overview of the main layers rather than the intricacies that are skin anatomy. So the layers consist of the epidermis, which is the top layer, the dermis, which is our second layer, and subcutaneous tissue, which is the last layer. Once you get past subcu tissue, you get more into vasculature, muscle, fascia, um, tendons, all the things. It just depends on the location at which you're looking at. So the epidermis, it is the outermost layer of the skin. It includes keratinocytes, which give us most of the protection we have against lots of things. And it has melanocytes, which produce pigment. It is a vital protective barrier against pathogens, against UV radiation, water loss, and it also produces new skin cells for us, generates melanin for skin color, as I said, and it also houses immune cells to fight infections. I often describe the epidermis to my patients as an umbrella, as it takes a lot of the damage and does an incredible amount of work, right? So what do you need to know about the epidermis? I would think that all you need to really know is that it needs to stay protected. Just like the epidermis and an umbrella. The umbrella protects against heat and sun and rain, but over time, it starts to fade and lose its strength. So we have to protect our umbrella or our top layer of skin by using sunscreen, UPF clothing, and good skincare. And that way we can keep our epidermis or our umbrella looking alive and healthy. So the dermis is the second layer of skin, and it has a lot of roles. You won't see the dermis with your eyes, but it is consistently producing and repairing collagen. It repairs blood and vessels and nerves and hair follicles. All the things that keep our skin perfused and feeling good. The dermis is akin to a manager because it manages all of those functions that are essential. It has a lot of jobs and delegation at play. And so what you need to know about protecting the dermis is that it starts with protecting the epidermis. So lastly, subcu tissue provides insulation, cushioning, and structural support. Often, as we age, you've probably noticed that older patients, older clients, your parents, they bleed more often, their skin is thinner, it may tear, and you can see those visible blood vessels under their skin. And that's because as you get older, we often lose significant amounts of subcutaneous tissue or fat, and that fatty tissue is what protects the skin from all those injuries. And so once we get older, we start, bumping and bleeding and becoming more fragile. So what do you need to know about subcutaneous tissue? Not much. But if you see it, then you should definitely encourage them to see someone in healthcare because you should not be seeing someone's subcutaneous tissue. I did include this graphic here because it has a good representation of the layers and kind of how deep they are. Subcu tissue is pretty deep, right? And so that's just a good visual. The scalp. So the scalp has many of the same skin layers, but I felt that it was important to mention separately because of the chronic sun exposure risk that's associated with it. If you think about it, we're always outside, most often without a hat, and the crown, the part of your hair, and if you have light colored hair, maybe your entire scalp is getting chronic sun exposure and you don't realize it. In practice in dermatology, men especially have the most precancerous lesions on the scalp. So it's just really important to encourage your clients to protect their scalps, whether that be with sunscreen, with a wide brim hat, or just seeking shade when they're outside without protection. So next we're going to discuss benign lesions. Benign lesions are those lesions that have no negative consequences to your health. You will find that many people may be unhappy with them as it may dampen their appearance or their self-esteem, but these are not urgent issues to be treated. We will get into some diagnoses that you may commonly see in your work as as a professional in personal care. So I put the little graphic here. Don't worry, be happy, like I said, because it shouldn't stress you out too much. So what is your role as a hairdresser, as a tattoo artist, as a makeup artist, estheticians, nail techs, all of you? What is your role in recognizing these type of lesions? So this program, the Referral Network program, it doesn't give you the ability to diagnose or to give your feedback on it, unfortunately, but it does give you a basic understanding of what is concerning and what is harmless. And so this Referral Network program gives you the opportunity to refer to a clinic. So I just don't want you to place the pressure of diagnosing someone or stepping out of your scope of practice by making a diagnosis. So I am sure that you've seen this in your lifetime at some point. This is a seborrheic keratosis. We also call it an SK. It has kind of a stuck-on appearance, almost as if you could just easily grab it and just pull it right off of the skin. They're commonly like waxy or maybe dry and crusty, and they're typically brown or black. Sometimes they're skin colored, especially if they're new. It's unknown why they occur, but we do know that they are always harmless. There is a genetic component to it, and they itch. That's probably the most common complaint I get in practices. It itches or it gets caught on clothing. So the next one, these are cherry angiomas. These can be scary and reasonably so. They're red. People mistaken these for melanoma or just they get concerned with them. And so I get a lot of patients that ask me about them, and it's a cherry angioma. It's basically just a superficial vascular lesion. There are some underlying conditions that may cause them, such as hormonal changes or alcohol use excessively, but typically they're just genetic or they're age-related and they're not concerning. Lastly, you will undoubtedly notice moles that look funky. Sometimes that's just the way that our body makes them. Sometimes they're abnormal or dysplastic, and sometimes they're totally fine. It's hard to decide. And so for you, you should always utilize your melanoma reference cards to assess it. And so if it meets 2 out of 5 criteria, that's typically enough for me to be concerned and possibly biopsy it. So for you, it should be worth sending to a provider for an evaluation. And we will get into the melanoma reference card shortly and discuss all the details about that. Precancerous lesions. So precancerous does not mean safe. And that's a hard thing for me to instill into people, into their brain. Precancerous lesions mean that you are in the process of developing a skin cancer. And sometimes that can be a life-threatening condition. Skin cancers are not limited to just the skin. And if left untreated, they can progress to muscle, organs, lymph nodes, bone. They can kill you. And so 2 precancerous lesions that I would like to discuss today are the most common that I see in practice. One is dysplastic nevi, and 2 are actinic keratoses. So dysplastic nevus. This is a mole that's cellular makeup is abnormal. They can quickly or slowly develop into melanoma if left untreated and unassessed. So there are 3 levels of dysplasia, and those include mild, moderate, and severely dysplastic. And so as these progress, the risk of melanoma increases much more rapidly and drastically. And so this is the same type of conversation that we had about benign moles or benign nevi. It is too hard to determine based on your experience. So if you are concerned, you should refer these clients to a provider for proper evaluation. I always recommend using the ABCDEs. And again, if they meet 2 out of 5 criteria, you should refer them to a provider in the clinic, a referral network program. So this is our ABCDEs of melanoma. This is one that the Closer Look Project has, and so let's go through it. So A stands for asymmetry. So basically, if you were to cut something in half, it should be symmetric on both sides. It should not, it shouldn't vary in size on either side. B is for border irregularities. So that border looks pretty jagged. It should be pretty uniform and round. It shouldn't have a lot of jagged edges. Color variation is what C stands for. And that means, like, if you see a mole that has more than one color in it, that could be a concerning sign. It shouldn't be pink, it shouldn't be red, it should be brown or even a darker brown. And if it is pink or red, as long as it's one full color, it's less concerning. But like I said, if it's more than one color, that is a red flag. D stands for diameter. So anything greater than 6 millimeters or the size of a pencil eraser. And E is for evolution. So if it is evolving over time, that could be a sign that it's progressing to a dysplastic mole or a melanoma as well. And I will say that the ABCDE melanoma reference cards can be found on our shop. You can buy them like in bulk. I'm not sure of the price right off the top of my head, but you can check those out. So next, these are actinic keratoses. Actinic refers to sun damage, and keratoses is basically just the keratinocytes that are kind of responding and building. These lesions are most commonly found in the highly sun exposed areas like your face, your ears, your scalp, hands, arms, and maybe your upper chest. They're technically very early phase squamous cell carcinomas, but they're very superficial and can be treated quickly and effectively with less invasive treatments such as cryotherapy, where we freeze it, light therapies such as blue light, or topical medications like Efudex or imiquimod. So the complaint with these lesions is typically that they are recurrent, dry, itchy, and they often thicken up as they progress. They appear as erythematous keratotic plaques. So these should be referred to a provider ASAP for secondary preventative measures. And so you can see, hopefully, how, like, this is more of a severe case, but you can see that these are earlier phase actinic keratoses, and these I would probably call early squamous cell carcinoma because they've kind of progressed significantly. And then these are commonly how they appear in the clinic. And you would think that it's just a dry patch or eczema or something, but if they're erythematous like these are, and they're itching and they're painful and they possibly bleed, it's not worth it to let those go without monitoring or treating. Malignant lesions. Run, Forrest, run! So, malignant lesions are skin cancers that progress to invasive cancer, or that can progress. These are no joke, and you should send your clients running to a provider for timely assessment. This is a good time to mention also, for those of you who wonder, like, how in the world can I refer someone in a timely manner? Like, that's unheard of, right? If you join our program, our training referral program, by purchasing the materials in our shop, then our team actively begins searching for clinics in the area to join our program for you to refer them to. So malignant lesions include basal cell carcinoma, squamous cell carcinoma, and melanoma. And there are a few others of note, but these are the most common and the most likely that you would see. So this is a basal cell carcinoma, otherwise known as BCC. I've heard many providers say, like, if you were to want a skin cancer, you would want a basal cell. And the reason they say that is because it's incredibly slow growing, but the statement may seem a bit insensitive. So this is the most common type of skin cancer that we see. It's the slowest growing, and it's the least likely to become invasive with metastasis, but it can happen. If you take a look at the features, you will see a pearly papule with central ulceration. Now that's more of a later sign. Typically it starts out as just a pearly papule, but that ulceration can cause some rolled borders, as you can probably appreciate there. And then sometimes, and you can't really make it out in this photo, you'll see telangiectasias, which are blood vessels that are kind of crossing through the tumor. So this is a squamous cell carcinoma, or SCC. SCC is another common skin cancer, the second most common, and these photos are actually from a consenting patient of mine whom I treated over the past few weeks. She had never had a skin exam, but when she came in to see me, I identified 3 concerning lesions. Number 1 here and number 2 here had been there for quite a long time, she had said, and she reported that they itch, they were painful, and she said that sometimes they become smaller, but they never fully heal. In addition, there is significant erythema there as well. So the most common presentation is going to be pretty similar to what I just told you she reported to me. Plus, they're going to be scaly, crusty, and rapidly grow. In elderly patients, you may find that there was some type of injury before the lesion appeared, such as like a fall or a cut, and those are considered reactive squamous cell carcinomas, and they all warrant a referral to one of the clinics in the referral network program. So this is probably a more advanced version of it. This one is it's a squamous cell carcinoma, but it was invasive, just to the dermis as well. And then this is the excision of number 2. So melanoma, that is the big word. Melanoma is a rapidly progressing skin cancer that can and will metastasize to deeper structures, and it's one of the most deadly cancers out there. We could get into all the details of staging and workups and all the things, but for the purposes of this lecture, you just need to know that it should not be taken lightly and it should be referred as soon as possible. And take a look at this photo. Ask yourself, is that asymmetric, right? So we cut a line through it. That would clearly be different on each side. And then we look at the border, right? So you see lots of jagged markings here. That's an irregular border. Then we look at color. You see black here. You can see some red there, some brown. So I mean, that's 3 colors there. That's not great. And then, is it larger than 6 millimeters? This circle here is supposed to be 6 millimeters, or the size of a pencil eraser. That is 4 out of 5 criteria and highly suspicious for melanoma. I would recommend that you refer this to a provider ASAP. Next, we have skin of color considerations. So it's very important that we understand and recognize that skin of color presents differently than non-melanated skin. That is just the truth. My experience, I would like to share a story about one of my first experiences with a patient of color. She was a black woman and had several spots, lesions that looked like what I thought were epidermal inclusion cysts, or EIC. But the pigmentation and the difference in the skin texture and even the appearance on the dermatoscope was very difficult for me to determine if it was an EIC or a dermatofibroma, which is basically a deep scar, or just a mole or nevus. So I talked to her about my hesitancy. I was very upfront and transparent. And I said, listen, I don't want to just brush this off. I don't want to say it's likely this and just send you out. Because, I wasn't as accustomed to skin of color treatment as at that point in my career. So I offered to her a biopsy. She was such an amazing person to learn alongside of, because it made me realize that so many textbooks focus on white skin, and hardly any of them teach us about skin of color, and the differences are frequent. They're frequently there. And so it was a really great experience for me to have this black woman as a patient and for her to be as interested in learning about her body as I was. And she really appreciated that effort that I made. And, many patients don't receive that compassion or that transparency because not knowing as a medical provider can be a scary feeling for some. But if you ever experience this, just make sure that you place yourself in the patient's shoes. Think about their experience. Imagine how they feel. Imagine how scary it is for them to feel dismissed or to receive an answer that's just inaccurate. So next, let's talk about some resources. So this resource is called Dermatology for Skin of Color by Susan Taylor and Paul Kelly. This book I received from a pharma company early on in my dermatology career, and it was so wonderful. The book has photos from so many different ethnicities and skin types and skin tones and colors, and it just really allows you to see that it's much different for certain skins. And so I recommend this book to everyone. This is a great resource. Does anybody recognize this man? That's right. This is Bob Marley, and he died from acral lentiginous melanoma on his foot. And so melanoma in skin of color often presents acrally, which means on the palms or soles, and sometimes subungally, like under the nail. And so something to be aware of is that a lot of black patients may have this happening, or they may have melanonychia, which is the black streak, and it can look like melanoma under the nail. But you need to educate yourself on the difference, and there are differences, and we can get into that in another video. Then we talk about basal cell carcinoma in skin of color, and we also talk about inflammation, infection, and malignancy. So skin of color will not present oftentimes as erythema when there's a rash. A basal cell may not look like a pearly papule, and the rash will likely be a darker hue or a violaceous presentation, depending on the tone. And a basal cell may just look like a normal mole or even a scar. So make sure that you're educated about the demographic you're reaching. It will make a world of difference. So here are some takeaways. Understanding that skin anatomy can help you build recognition skills is an amazing tool and opportunity for growth. Not all lesions are dangerous, but early recognition is crucial. Inclusive awareness ensures that no patient population is overlooked. And back to the anatomy part, if you know what's normal, you know what's abnormal. So what's next? Next week, you can catch Chapter 3 of the Learning Program Workbook, which will discuss the skin exam and the tools for our community frontline team members. Thank you so much for joining Chapter 2 of the Closer Look Project Training Program. So please send me an email if you enjoyed the content. Check out our socials and send us an email or a comment or whatever. Let us know where you're watching from. Let us know what you think could be better. I would love to get your feedback. All right, we will see you next week.